Hello, Section 5. I hope this weekend wrap up finds you all doing well and ready to be done with our 8 weeks of upper extremity disorders. It's been this last block I really enjoy because I really like to see people's wheels turning, and I like to see how everyone engages in regards to what they do clinically. And I don't, there's not a lot of right or wrong answers in these things. There are some, I guess there are some definitives that we need to be able to see, and we're looking for this kind of thought process that has hopefully evolved over the last 8 weeks based on the information that's presented. So I really do enjoy getting to kind of peek inside why you do what you do. And so it was really good, and hopefully everybody can now take a deep breath and relax a little bit before, before another course starts. So let's get to the summary. So tying it all together. So this was a complex case, right? These people come in with a number of things wrong. I don't know how people handle that in your clinic. I think one of the beauties of going through fellowship is that it makes complex cases not so complex. You're able to you're forced through a lot of repetition to really be able to break these down relatively quickly and come up with a treatment plan and something that I think you can really affect quickly. The medical screening was really important. This woman had a number of things going on that maybe not definitive red flags, but things that you need to keep an eye on and need to have in the back of your head. And I think that that's true for a lot of patients. And even if they've come referred from primary care, in the back of your head, you have to be thinking, if I'm not making progress, there's something that's not right here. What are the other possibilities? Or if they don't respond in a musculoskeletal evaluation, what are the possibilities? Is this a cardiac issue? Is this potentially a lung issue? Is this are there other things at play? I don't need to know what they are. That's not my job. But I can certainly in the back of my mind be like, this doesn't seem to fit. And so you need to be able to say, first thing, do they belong in my office? Planning your exam. I think the SINS is a great way to help everybody prioritize what your patient has going on. In this case, what this woman had going on. It allows you to break the information down. And when you get stuck in your mind, this is a great thing to do. Some things are pretty straightforward. Patellofemoral pain. I'm a runner. I have knee pain, right? Like you get that. But people who come in with multiple complaints, have chronic pain, maybe multiple comorbidities because they have chronic health issues that maybe not even musculoskeletal, but they can make things a lot more complicated. The SINS is a great way to kind of get a handle on, and especially if they have kind of pain in a variety of areas. And then this helps you align your hypothesis with your treatment and your home exercise program. Test, retest. This is what helps us validate validate our hypothesis and validate that what we think we are doing is right? We formulate a hypothesis, we test it based on a patient's ability to do or not do something, we apply a treatment, we retest, and we see if we're right. Clinical reasoning components, right? How you move through things. Once you've applied the treatment, where do you go from here? I felt one of the most interesting conversations that I was able to have was when the people, one of the last questions, not the last question, but one of the last questions, if your patient is better, what do you do? If your patient doesn't change, what do you do? And if your patient comes back worse, what do you do? I feel like everybody had a really good handle on if they were worse. I mean, I think you all understand if they're worse, you've pushed them too hard and you need to back off. If they're better, I thought, some people said they would do the same thing. I would say for sure I would do the same thing, but I would also challenge you to perhaps be a little bit more aggressive in your treatment to try to move them further down the road. Obviously appreciating their level of irritability, and that irritability is a big deal, and monitoring that and understanding that. We've talked about irritability with tendinopathy. That's kind of easy to assess. Irritability, nerve tissue irritability, a little it's still able to assess, but probably not as consistent based on what we know in the research, and that people can have nerve irritability can kind of behave in some odd ways. It's no change that becomes a problem. When they don't change, what do we do? Do we go to another area? That was an option some people chose to do. I would argue we push harder. This is the worst case scenario in my opinion. If they don't change, if you don't get a change from your treatment, that's a problem. And we're either gonna be way more aggressive, or that's it. I mean, that's how I go. We go way more aggressive. And so I want you to appreciate that too. If they don't change and you do the same thing, you don't have an idea of what's going on, and you need to know what's going on because you need to understand the irritability of this. And are they a musculoskeletal patient? Some lessons learned. Yellow flag screening. So, this woman had she had some anxiety, perhaps some depression issues going on. She had a pretty stressful, her life, the wheels were coming off the bus on her life. And there is no reason when she looks back in a year, she'll look back on this time and be like, oh, well, no wonder my pain was high. And no wonder my life was not great. That's the depression screen. The depression screen PHQ-2 is a must. And then my question to some of you is, once you know that information, so they have to have 3 or higher to be referred to potentially be referred for further examination. In my department, I work in a hospital-based setting, so we can push them up to primary care, and primary care is fully aware of this. They would want this. If you're in a private practice setting, what do you have in place that affords you the ability to address this issue, right? What are you going to do? So if you don't have a plan, I get a plan. And that can be something as simple as making sure that they have a mental health practitioner. If they don't, helping them find one, following up with them on one, helping them understand that pain is heightened because of depression and anxiety. And so somebody who doesn't have pain might have a 3 out of 10. And because your pain is interwoven with your depression, it could be a 6 out of 10, which is, there's a big difference between a 3 and a 6 as far as how you live your life and how you sleep and those kinds of things. And so it's really important for the patient to understand. Once they understand, maybe part of them fully recovering is getting depression under control, or that they won't recover until the depression is manageable. That's a big deal. Separating out the P's for specificity and clarity, right? We had a little bit of that. I felt like there was a little, but most people understood the different P's, P1, P2, P3, and that's helpful for you. Sometimes I'll even have the patient mark, I want you to put your number one problem, put a number 1 on where you feel the number 1 problem is. I'll have them do that on the body diagram, as well as number 2 and number 3. Prioritize. And that, that's about the patient. Asking the patient, what do you want addressed first? And even saying, obviously we all have the ability to say, well, we can't address all of this today. What do you want to address first? I think that's really important. It'd be my opinion. It's my opinion that you treated this woman's neck and her shoulder's going to get a lot better. That would be my opinion. That the neck was going to be unlocking a lot of, her P3 was going to feel better. Her P2 was going to be better. May not be all better, because there's a good chance she could have a frozen shoulder. There's a good chance other things, some weakness playing into it, some scapular dyskinesia, and those kinds of things. But my guess is that you would have reduced her pain pretty quickly by just going in and doing some side glides, some AP mobilizations, maybe some manipulation, depending on how comfortable you feel. Maybe not on the first visit, but the second. Okay, wrap up discussions today. Get after it. I'm doing this a little bit early because I have to go volunteer at a basketball tournament from 2 o'clock until 10 tonight, and I wanted to get this up. Complete the course critique. Please rip me if you need to. It helps me learn, helps me better help you guys. I'm always open to criticism about how we can help you, how EIM can help you, what would be helpful for you guys, so that we can create the optimal learning environment. But please fill out the course eval. I don't think you can actually complete the course without doing that. So we as faculty and TAs have thoroughly enjoyed working with each of you. Yeah, I always love these courses. I love hearing what everybody has to say. I love the dialogue. I love the banter. I love the thoughtful conversations that come about. And of course, we wish you all the best of luck moving forward. And I just want to give a huge thank you to Eric and Laura. I can't, without my fit TAs, I can't. It's hard to manage. I've worked with fewer, and it's harder. These guys were great. They're very, I find them to be highly intelligent, highly thoughtful, and highly skilled clinicians. And it was an honor to have them not only guiding you guys as I read through some of their banter with you guys, but then just watching them work in the FIT projects and hearing them dialogue about the things that they are struggling with or what they're trying to work on to be better. All of us working toward that better goal of just to help our patients have a better, more positive experience. So again, thanks to Eric and Laura. Thank you to all of you. Hope you all have an enjoyable rest of your spring. And if ever in Minneapolis, Minnesota, feel free to look me up. And if ever any questions arise, you can always hit me on email. Glad to converse there as well. So take good care to all of you.